I'd like to welcome everybody tonight to the February meeting of the Fort Worth Surgical Society, and thank Scott Blumendahl for reminding me, and did Scott slip out? I guess he's finishing up. That our meeting would fall on Valentine's Day, and so thanks Scott for reminding me, and so this has all worked out pretty well. We have some, welcome everybody, we have some guests tonight. Aaron Eves is with us again from Hill College. Aaron, you're always welcome. Dr. Michael Ross, one of our local hematology oncologists, a good friend of mine. Michael's here tonight. Thank you, Michael. The former president of the Tarrant County Medical Society, Dr. Gregory Phillips. Greg, thanks for joining us tonight.
Immediate past president.
Immediate past.
The other past presidents.
Immediate past president.
That's right.
Yeah, Dr. Steve Brotherton.
Exactly.
One of my medical students, and I'm pleased to hear that he matched this spring at Harrisburg, Pennsylvania, Stephen Atkinson. Stephen, welcome. One of our candidate group members, Dr. William Crawford, is with us tonight, and we hope the phone stays quiet. So, welcome, welcome everybody. I also want to say, as always, thank you to our Moncrief Cancer Institute partners. We are able to do this and do the things we're doing because of the great help we have with everybody, especially with our IT group, Dawn, and welcome back Jonathan Loudermilk. So we're at full strength tonight. Our remote partners out in Decatur at Wise Medical Center are joining us tonight. They're muted, so we don't have any echoes or whatnot, but we'll be getting questions of them hopefully afterwards. This is your Fort Worth Surgical Society Executive Committee. This is our schedule the remainder of the year. The March meeting is going to be our first drug company sponsored boondoggle. Dr. Philip Woodworth's going to be talking to us, and his topic is to be announced. Dr. Habash will talk to us about breast reconstruction, and I'm looking forward to the 53rd R.J. White lecture about vascular surgery update 2017. Where is the pendulum? Are we doing too much endovascular, too little endovascular? This will be a nice, very brisk and frank discussion with Dr. Mills. Looking forward to that. Now, it's a little housekeeping. You will get a CME credit. This is the way, for tonight's meeting, this is the way you have to do it. I think everybody has picked up these handouts. You can do it either on the internet or by your cell phone. This is event 348204. I just did this over the weekend. For credit for the meeting we did over UNT Health Science Center. It's really pretty easy. We are going to, as I mentioned last meeting, we have an initiative now with the Fort Worth Dental Society. They would like us to do some social events with them and meet together. We're exploring this. They visited earlier tonight, the president, Amy Bender, and the incoming president, Joe Laborde. They are, and we'll get more details for you, they've invited any of us to their fundraising golf tournament this spring. It'll be Friday, April 28th. We'll have more details for you at the next meeting and in our emails. I want to remind you, if you miss a meeting, all of our lectures are now being recorded, as is this one tonight, and they are archived on our website. I have the December meeting here, but Matt Fultz's lecture about thyroid nodules in January is also on the website. So you can look at the lecture on the website. We are trying to figure out how to get CME credit for that. We'll solve that. So they'll be recorded and embedded from now on. Actually, Dr. Yarbati is with us here tonight. We have a new initiative with the UNT Health Science Center, Department of Surgery, beginning, I think, in September. We're going to be part of their surgical grand rounds, which will increase our attendance, and we're happy to help out the residency over at Plaza. Yeah, if we have been emailing back and forth. If you need a speaker, maybe some members of our society can be speakers at your grand rounds over there. I'm going to breeze through some of the CME things coming up. We'll probably go ahead and starting next time have these out for everybody to look at. I did leave this flyer out there, the Houston Aortic Symposium down in Houston, a 3-day event is down they're starting this weekend. As you all know, the North Texas chapter is meeting together with, this February, actually this weekend, with the South Texas chapter in Austin. There is a minimally invasive surgery symposium coming up in, when is this one here? This is in Las Vegas. let's see, when was that one? That is,
December the 2nd.
doesn't say there very well. We have a hernia society meeting coming up in March in Cancun. The Harris Trauma Symposium, the yearly symposium is Thursday, April 6th. The good-looking Tulane Symposium on thyroid and parathyroid diseases, April 30th. A new colorectal meeting in Boston in May. And Dr. Mathieson, who was our R.J. White speaker last May, is he and his department are having their annual terrific general thoracic surgery meeting in Boston in late May. So a lot of things going on in the academic world. Some good CME courses if you're interested. Our guest tonight is one of our members, Dr. Hossein Bagshai, and I'm really excited to hear his talk. Dr. Bagshai is from Irving, from Iran originally. He grew up in Irving, undergraduate degree, University of Texas in Austin, surgical training up in Worcester, Massachusetts, and then a fellowship at UT Houston in bariatric and robotic surgery. Hossein is active in the bariatric surgery field. He's going to talk to us tonight on bariatric surgery. Where are we in 2017? The good, the bad, and the ugly. What a great title. Hossein, welcome.
So I want to thank you tonight for inviting me to speak on bariatric surgery. I know it's done in pretty high volume in Dallas, Fort Worth area, probably more so than a lot of other major metropolitan cities. And so there's a lot of patients that have had it in the distant past, recent past, or acutely and ending up in various ERs. So I wanted to talk about, I've always liked that movie, The Good, Bad, and the Ugly, and that title stuck with me more than the plot line of that movie as I watched it as a kid. But that's what bariatric surgery is. It's good. It has some bad components, and it can turn ugly really bad. So hopefully we'll touch on some of that. The objectives are going to be to talk about bariatric procedures that are most commonly encountered today, maybe some of the things that are on the horizon and some of the things that are being done under IRB protocol, recognize some common complications and discuss the management of those complications and how they're evolving. But at the end of it all, I really want to just stress to everyone to think of it as GI surgery. It's really not a whole lot different than what a typical general surgeon or a gastrointestinal surgeon would deal with. Bariatric surgery, Ed Mason, who's known to be the father of bariatric surgery from University of Iowa, he best described it as using the known side effects of GI surgery for the treatment of a new epidemic, and that's obesity, essentially. So getting right into it, the prevalence of obesity, obviously, we're very well aware of it. I mean, everyone is obese. About a third of the U.S. population is obese with a BMI above 30 and 35, of about 35%. It afflicts the children and adolescents. 17% of those kids are obese and going to be obese into adulthood. And it accounts for about 21% of our U.S. healthcare costs, and it's projected to increase to 42% by 2030. So it's a pretty serious problem. If you've gone to any surgical talk related to obesity, I'm sure you've seen this heat map as it's developed from the 80s. This is the 2010. I think there's a 2015, but somehow they changed the colors. But the red states are the states that have an obesity rate above 30%, and ours here in Texas is right around 34%, with Mississippi being the winner, close to about 35%. And the reason is, we as an American society we're obesogenic. It's characterized by environments that promote increased food intake, non-healthy foods, and physical inactivity. So this is a great cartoon kind of depicting that. David's here for 2 years. He ends up like the rest of us. And when we're prone to it too. Our own families, ourselves, if we're not careful as well. Just we're in the environment. So what exactly is obesity? Well, in a broad sense, it's a lifelong, progressive, life-threatening, costly, multifactorial disease, and we need to start talking about it as a disease of excess fat storage and multiple comorbidities that are related. Why weight loss surgery? Well, individuals with a BMI of 30 and above have a 50 to 100% increased risk of premature death compared to a healthy weight individual. A BMI is a strong predictor of mortality. With a BMI above 30 to 35, life expectancy is shortened 2 to 4 years and 8 to 10 years for someone that's morbidly obese, which is a BMI of 40 or above. In fact, the risk of death exponentially increases as you start passing a BMI of 40, and it affects essentially every organ system. You know, when I'm speaking colloquially with my patients, it's basically, you know, taking a Corolla and then hitching a trailer to it and driving it all around town. Everything is going to give, the transmission, the brakes, and so on and so on. And essentially that's what we see in the patients. You know, with bariatric surgery, you can manage a lot of these diseases by treating the upstream disease, which is the weight that's driving all this. It's very costly, and we're in an environment where every dollar we spend on healthcare is being scrutinized, and where can we save it and where can we be efficient? Well, obesity is one of those. By CMS data, you know, there's an $1,800 higher per year cost of obesity versus normal weight, and $5,500 per year in morbid obesity versus normal weight. An increase of BMI by 5 increases the risk of endometrial cancer, kidney cancer by 30 to 60%, and increases the risk of colorectal and pancreatic and breast cancer by 13 to 18%. So essentially any estrogen-sensitive cancer is affected. AMA has officially recognizes it as a disease since 2013, which was a big push forward for trying to approach it that way. It's no longer taboo cosmetic surgery. We need to stop thinking about it that way and stop talking about it in that manner. And we know that diet and exercise is a component of bariatric surgery and a healthy living, but that alone in the morbidly obese population leads to 95% failure rate. It's now safer than it ever has been before, so the risks of surgery or the risks of being obese are far outweighed by the risks of surgery alone. It improves and resolves a lot of health-related comorbidities, and payers recover their costs within 2 to 4 years, and it improves life expectancy by up to 90%. It's recognized and endorsed by many national organizations, including the NIH, ADA, American Heart Association, and the AMA. So who's eligible? In broad terms, by NIH consensus criteria set in 1992, anyone with a BMI of 40 or above, you're qualified for bariatric surgery, or anyone with a BMI of 35 with one major obesity-related comorbidity, which is type 2 diabetes, sleep apnea, and cardiovascular disease, which is kind of like a grab bag of hypertension, hypercholesterolemia, or CAD. But I will tell you, for a lot of bariatric practices and with ASMBS, these are kind of the criteria that insurers will use to cover it if they offer that to their employee and so on. But most bariatric surgeons, if someone's BMI is 30 and above with one comorbidity or is a good candidate, will offer this operation. They must have tried and failed other weight loss attempts, been overweight for at least 2 to 5 years, and are prepared to attend regular follow-up and make the lifestyle changes that we were recommending to them, and participate in active groups and so on, and healthy enough to tolerate the operation. So we ask them oftentimes to, everyone wants them to exercise and eat well, and this is what you get. So bariatric surgery has been around 60 plus years, again with a colloquium of general GI surgeons starting in Iowa. There have been various iterations of operations, which I'm sure many of you are familiar with, that have kind of made it into the book chapters and gone away. So we kind of have the perfect storm right now. There's an obesity pandemic. We have an advancement of GI surgery. It's all laparoscopic compared to open. So operating on an obese patient has gotten a lot easier and safer. We have improved perioperative monitoring. And it's a very progressive area of GI surgery. I mean, from meeting to meeting that we go to in bariatric surgery, there's a new procedure, a new technique, a new device. So it's very exciting. So the device makers and industry has really gotten behind it. So, and again, safer than ever. So it's a growing field and will continue to grow as well. No pun intended. So why so much bariatric marketing? I'm sure you guys are tired of seeing the billboards as much as I am, but it's mainly because there's limited physician-driven referrals. A lot of the patients are direct referrals. They're tired of being obese. They're tired of their doctor telling them that they are obese and they need to exercise and do this, that, and the other, but no one ever really talking to them about bariatric surgery. About a third of the patients you're seeing, whether you like it or not, are obese or could qualify for weight loss surgery. And, National Healthcare Disparities Report this was a great comment out of it. Despite the rising rate of obesity, less patients are being informed that they're obese or overweight by their healthcare professionals. And I've had these conversations with primary cares and urologists and orthopedists, and they're, the specialists I could understand. They're like, I'm an orthopedist. They come to me for a knee problem. I tell them that their weight's driving it, but I really have a hard time sending them out of my office, telling them to go have another operation. And with the primary cares, there's a barrier that I'm not sure should exist or not, of introducing, the concept of weight loss surgery for weight management. I'm not immune to it either. I do some marketing myself and always constantly trying to figure out how to get patients through the door. With all that, the rates of bariatric surgery are increasing. In 2015, we had about 200,000 bariatric operations. Now, the pattern is changing a little bit. A couple of years ago, we were mostly doing Roux-en-Y gastric bypass and lap bands. And as sleeve gastrectomy became popular, that has quickly eclipsed lap band. It's almost, we're not seeing much of that anymore. And Roux-en-Y even has gone down pretty dramatically. We still see a small number of biliopancreatic diversion, not a whole lot in Texas, some duodenal switch, but that's still under 1%. We're seeing a lot more revisions. I'm very honest in admitting that obesity is a chronic disease, and these operations are just tools in the management of that. We're not curing anybody of their disease. So you are going to have some degree of weight loss failure, whether it's a mechanical problem with the operation or weight regain or weight loss failure. We are going to see revision rates go up dramatically over the next 5 to 10 years. And there's other devices. We had 700 cases of intragastric balloons, which I'll show you and talk about, and we have device makers behind it. So we're seeing vagal nerve stimulators coming on, but this hasn't necessarily hit prime time. And despite this growing area of bariatric surgery in the population, only 1% of qualified patients actually get it. Believe it or not, all the bariatric surgery you've seen, heard about, or are aware of, that represents less than 1% of the population that's eligible to get the operation. But in Dallas, it's skewed a little bit because bariatric surgery in Dallas-Fort Worth is kind of like cosmetic surgery in Beverly Hills. There's many surgeons, and the market has really been developed to where patients are aware of it and seeking it out. Classically, these operations were classified as, and are classified as restrictive. We used to call it malabsorptive or a combination of both. We've kind of shifted away from malabsorptive to metabolic as we're learning more about how gut physiology changes. And then devices kind of fit in here somewhere. We're just not sure exactly where. So this is lap band, sleeve gastrectomy, which is the most common operation now, Roux-en-Y gastric bypass, and duodenal switch with sleeve gastrectomy. Now, this is the same operations up here that I just mentioned. This is also a duodenal switch, just a newer version of doing it. The reason I think, or for myself particularly, we didn't get into duodenal switch is, it's a technically difficult operation, for this duodenal dissection, and the Roux-en-Y component's not all that hard. But finding the right patient for this, this is one of the more malabsorptive operations, so long-term follow-up and compliance is really, really important, or patients get into trouble. There are two centers that kind of popularize what's called a loop duodenal switch. Essentially, the duodenal dissection is the same, but there's no Roux-en-Y component to the BP diversion, and so you get an afferent limb and an efferent limb, a small bowel. Typically, we count back 300 centimeters and then do the anastomose, the first portion of the duodenum, to the small bowel. Weight loss profile with it is just a little bit better than Roux-en-Y gastric bypass, but the long-term complication rates of nutritional and protein deficiency is a lot less, so we're going to probably see a lot more of these coming on board. And the others are kind of experimental operations that have come and gone. Mostly see them overseas, and in Brazil, believe it or not, is a very big player in weight loss surgery and developing and innovating new techniques. So this is an ileal transposition, if I can get the pointer to work. Mostly designed to treat diabetes along with weight loss, but in the US it's all done under IRB protocol. I don't think it's going to take off. Kind of a technically challenging operation, try to keep the limbs organized and going from there. This is what was called a mini gastric bypass or a loop gastric bypass. So Same idea as the loop duodenal switch, but you kind of make a mini sleeve gastrectomy here and then bring up an afferent limb and an efferent limb. A lot of these patients are coming back having to have these revised for bile reflux. It's actually still kind of in the development phase. So all these operations are going on in the background despite what we're seeing in prime time here. So devices, intragastric balloons, if you've seen TV commercials, billboards, magazines, things like that, well, it actually was introduced in the early 80s. It was a cylindrical balloon, limited success rates and really high complication rates, and it was quickly pulled off the shelf. And the thought was, you need a smooth surface and not this cylindrical thing that's going to erode into things. It stayed off the FDA-approved device list for a very long time. They've been used. The modern balloons have been used for about 15 years overseas, mainly in South America and Europe. They were invented here, but they had to go offshore to gain any success. We've had recent FDA approval of 3 different balloons, Orbera, Reshape, and Obalon, which I'll show you. They're recommended for a BMI of 30 to 40, off-label use for anyone with a BMI of 40 or above, or someone that's too high risk for a GI operation, or someone that is heavy, and we can use that as a bridge to surgery to get some weight loss. There's no insurance coverage for this, so it's all out of pocket. So I have not had a single patient come in for a bridge to surgery for that. So Orbera is made by Apollo, which bought up Allergan's bariatric division. They made the lap band and some other devices and this balloon. Essentially, it's like a breast tissue expander that's been kind of remodeled to be smooth. Once it's expanded, it sits in the body and the fundus of the stomach, occupies space, and is supposed to impart satiety. It holds anywhere from 400 to 700 cc's is what's recommended. So if I get a really large male coming in, I'll probably put in 550 to 700, where if I get a little old lady coming in, I'll put in closer to 450 and 500. Any science behind that? Not really. But that's how most of bariatric surgery is. A lot of it's just, experience and I guess what you feel comfortable with. So if one balloon is good, 2 must be better. So Reshape, made it in California, has 2 balloons. The concept here is it's also filled with methylene blue. The concept here is it's 2 balloons, so if one was to deflate, you leak out the methylene blue, and when the patient voids, the urine turns green, so they're alarmed or alerted, and they can contact their provider and either have the balloon fully removed and replaced. The chances of both of them going at the same time are pretty low, so you don't get the obstruction distally. If 1 and 2 are good, 3 must be better. So Obalon came up with a balloon that you basically swallow. It's attached to a tubing. This is swallowed in the office. First they come in, they swallow a patency balloon or a patency capsule to make sure that they can get it down. If they do, they swallow this balloon, and under fluoro, once it's in the stomach, it's attached to a tubing. You fill it with nitrogen. It holds about 250 cc's, and then you pull on the catheter, and it deploys it into the stomach. They feel that their balloon is better than the others because it's nitrogen filled, so it'll float in the stomach and be more in the body and the fundus where you want it to be, as opposed to traveling distally. They come back every couple of weeks, get number 2 and get number 3 in, so they get a total of about 750 cc's in over time, as opposed to getting it all at once and causing a lot of pain and nausea, which is the biggest issue with these operations, or with the intragastric device. So the advantages are it's endoscopic, it's reversible. Weight loss with it is total body weight of anywhere from 6 to 10%, looking at all the balloons together. They do have to be removed at 6 months. They will deteriorate, the stomach will break down anything you put in it over time, and they can travel distally and get obstructed, cause erosions and things of the sort. Disadvantages, it's costly. This is a completely self-pay procedure. It can impart some degree of reflux. It's contraindicated with anyone with a hiatus hernia of 3 centimeters or greater. They can cause ulcers. They can migrate and obstruct the pylorus. Or if they deflate, they can go into the small bowel and obstruct the small bowel. There was a recent FDA announcement on the fluid-filled balloons, a spontaneous expansion, and I'll show you one of those pictures. But this is what it looks like. So patient comes in, they get monitored anesthesia care, you put the endoscope down, you look at the stomach. If it looks fine, then you pass the device, you attach it to a one-way valve that it comes with, and you start filling it with saline. Once you fill it, you pull back on the tubing, it deploys and stays in the stomach. And then when you go back, you have a catheter with a needle. You pop it, push it into the balloon, pull the needle back, and then it's a catheter. You aspirate all the fluid, you go in with a fishhook grasper and remove it. Biggest issues immediately post-op is nausea, vomiting. They wake up, these patients, I've never seen buyer's remorse like this before. They wake up in PACU, either they're fine, they have some fullness, or they're just retching. But we've gotten really good with our anti-nausea cocktails. Emend, 40 milligrams PO before they even come in, a scopolamine patch, Decadron, and Zofran when they wake up and go home with oral dissolvable tablets of that. Usually covers it. And if they get through they will usually get through the first 24 to 48 hours, they're fine beyond that. It can cause, again, ulcers, erosions, pretty low risk of this, but we keep them on PPIs during the entire 6-month course of treatment. The obstructions come from either the fluid-filled balloons traveling distally into the antrum, kind of causing somewhat of a gastric outlet obstruction. Usually patients recover from that fine, but if they don't, we'll bring them into the office, lay them down, try to feel where it is, and try to gently press on it until it gets into the body and fundus, and you can kind of feel a release of air distally into the antrum because it kind of creates a little bit of a vacuum. I jokingly call it Leopold maneuvers that the obstetricians do. If it's still causing obstruction or repeat obstruction from this, whether you didn't put too much fluid in it or not enough fluid in it, you have to go in and remove it, and you remove it endoscopically like I described earlier. The key to these are that you remove them with the patient intubated under general, because typically they'll still have a lot of food around it despite being NPO. I keep them NPO for 3 or 4 days, or not NPO, excuse me, on clear liquids 3 or 4 days before they come in for the removal, and you still have a lot of food debris in the body and the fundus of the stomach. So even if you deflate the balloon, get all the fluid out, grasp it and pull it up, you just kind of wring out the balloon across the airway, and then they can aspirate when they wake up. So if you have an endotracheal tube in, you protect them from that. Patient reports a sudden loss of satiety. It's likely that it has deflated and gone into the small bowel. If it fully deflates, they can spontaneously pass it, especially the Orbera balloon. It doesn't really have a whole lot of things that can't collapse. The reshaped balloon a little bit less, and the Obalon, we don't have a whole lot of experience with here. If they do obstruct and they're not passing it, you either have to remove it laparoscopically or open, and we do consent them for that. This is what spontaneous expansion looks like. It kind of gets this air fluid level. There's been like 2 reported cases that the device maker will talk to you about, but I've seen this in the first patient I put it in. She was fine. She was pretty asymptomatic. They reported pancreatitis with this and potentially gastric rupture, but her patient did fine, and it came out a month or 2 later with no issues. If you see these, if you get a CT scan and you see this, make sure you ask the patient if they've had one of these or not, and not mistake it for some type of, GI cyst or thing of the sort. But that's what they look like. This is a procedure I don't do, but my mentors in Houston where I did fellowship were on an IRB protocol for it, and it's an endoscopic sleeve gastroplasty. So, as the field of endoscopy and endoscopic surgery advances, are doing more and more with it, and it's actually quite impressive. Again, Apollo, which is a company out of Austin, makes this endoscopic suturing device that sits on the end of a 2-channel therapeutic scope, and you go into the stomach here. So if this is the greater curve and lesser curve, you start to kind of mark out where you're going to put your line of plication. You put 1 line, 2 lines, and then you kind of zigzag across and serially crimp the stomach down. Now these are kind of crimped with little metal fasteners, but then the idea is to create an endoscopic sleeve. So this is before, after, and then 3 months down the road. That looks like a pretty good sleeve. I mean, it's not narrowed, it's not twisted, and that's pretty impressive. The largest series of it was an N50 out of Cleveland. They reported about a 57% excess weight loss at 12 months, 0 adverse events, took less than 2 hours. It's outpatient. So this could potentially have a future for patients that don't want surgery. If someone did that to my stomach, I would call it surgery. So and we kind of got to be honest about some of this stuff, because again, with the concept of obesity being a chronic disease and someone will probably need something down the road 5, 10, 15 years, I get really anxious trying to staple a pouch out of this or do anything to this stomach, because again, these are little metal fasteners, so, and that can derail any GI stapler pretty well, and set the patient up for leaks and staple line disruption. Others, I-band was essentially a lap band with a gastric plication underneath it. That's an abandoned procedure. V-block is a vagal nerve stimulator, which is reporting anywhere from 20 to 30% total body weight loss, which is still in development and is yet to come online. Endoluminal sleeve was promising. It was supposed to be the endoscopic gastric bypass. They've had some issues with getting it to stay at the EG junction and causing issues distally. And those of you that were general surgeons in the 80s and 90s that were familiar with Blake tubes can probably comment on these better than anyone else. And this procedure, which kind of baffles me and I refuse to admit exists, is basically surgically induced bulimia. The device is called Aspire. They have something similar to a G-tube. The patient eats, imbibes, does whatever they want. Once they've reached satiety, 20, 30 minutes later, they go stand, attach the device to it, and wash out about 30% of their caloric content into the commode. Yes, this exists. This exists, and we debate whether we should do it or let the general medical world take this over, and we're all pretty sickened by it. But this just speaks to what a big problem obesity is, and the type of thought that goes behind, and the innovation is people are coming up with these things because the need exists. Lap band, just getting into the popular operations you may be familiar with. Obviously lap band is no longer a popular operation. It's mostly abandoned, but we're going to be seeing a lot of it in its revisions, so it's worth talking about. Overall, pretty low risk procedure. Patients had a gradual weight loss from it, less vitamin and mineral deficiencies. It was touted as reversible. I take a lot of these out. I've taken out more than I've put in my career, and I can tell you it's removable. It's not reversible. Once you do a fundoplication up there, and depending on the band position and the scar tissue, it really does change things when you're planning a second operation. On average, less weight loss than sleeve and gastric bypass. Significant dietary follow-up is still required with this. Complications do occur, such as slip, erosion, gastric necrosis. I think this lap band kind of gets a bad rap because there are thousands and thousands of people that really benefit from this and continue to benefit from it. They've lost a lot of weight, they've stabilized, they've changed their lifestyle habits, and those are not the ones we're seeing in ERs and in clinics. They're doing fine. The ones we are seeing are the ones that are having problems with weight loss failure. Risks, obviously just any operation, infection, abscesses, outlet obstruction. It's a different type of outlet obstruction. Basically, this sits around the cardia of the stomach, so it's a functional partial gastric outlet obstruction. It can cause perforations and erosions. Mortality rate's still the lowest, and that's why it was so popular as compared to gastric bypass when they were both popular. So long-term outcome, it's an abandoned procedure. But we start getting the aftershocks in the ERs and in clinic with patients coming in super frustrated and a lot of symptoms. This is actually one of my patients. This is a posterior slip. You can tell by the band being more vertical, where an anterior slip, the band gets kind of flat and horizontal. We typically like for the band to sit somewhere between a 45-degree angle here. These can cause obstructions, dysphagia. Erosions are really bad, and I can show you some of those. This is a patient of mine, actually. I got called by another surgeon saying, I have a patient in my office that has their port site. These bands are connected to some tubing, and it sits on attached to a port on the anterior abdominal wall, much like a port someone would use for an infusion. And so, anytime you see a port infection, it's a band erosion until proven otherwise. And these happen slowly and insidiously over time, so the patients are not necessarily septic or ill when you see them. This was actually the tubing from the band. It had eroded into the greater curve of the stomach and back out of the antrum, and then went to the port on the anterior abdominal wall. This is a pretty big erosion. And then this is an obstruction from a band kind of causing a sigmoid esophagus. So, you know, if I see a patient like this, immediately I empty their band, whether they like it or not. They have various attachments to this device and what it's doing for them, but the great majority of them come in, they'll report dysphagia to liquids and solids, regurgitation, nocturnal symptoms. It's actually pretty bad. This patient of mine, she was actually a nurse. She'd had this band put in, had pretty good weight loss with it, and then slowly started to gain her weight back as she developed the dysphagia type issues and symptoms. And what they develop is a maladaptive eating behavior where solid foods they have trouble with, then they have, so they try soft, liquidy, high-calorie things to basically be able to get around the band, and that shoots their hunger drive up and also their caloric intake up, so they regain all their weight back, and they have an esophagus that's sigmoid, kind of like this. She had been lost to follow-up after a couple of years. She presented with dysphagia. I took the fluid out. She was still pretty symptomatic, but not so much so to where she didn't want to address her weight. She still wanted a gastric, you know, a gastric bypass is what she wanted, because you know, when we talked about the different operations, there was no way I would offer this patient a sleeve gastrectomy for anything. And I told her that we're going to take her band out and see what her esophagus does. I was not sure if this was going to recover or not in terms of her symptoms. And believe it or not, this is a month after the operation. She cleared most of the bolus. She still has some, you know, tertiary contractions and some difficulty, but symptoms essentially all but went away. She quickly put on 40, 50 pounds, and we're trying to get her ready for a gastric bypass. Band erosions, you know, are a lot different than just a band removal. If someone's having dysphagia, reflux, weight loss failure, and they just want the band out, which is typically what I'll recommend, that's a whole different operation than a band erosion. You know, they happen over time. They kind of erode through the body, through the wall of the stomach, but it gets concreted and scar between the liver, the diaphragm, omentum if it makes it up there. And so when you put the scope in, you can't find the band, you can't find the tubing. What you have to do is kind of poke on the port site to figure out where the tubing is coming out. Usually it's encased in omentum, and that's why they're not septic. You know, you bovie down onto the tubing. I would not use a harmonic scalpel on that. You can very easily aerosolize you know, silicone parts from this. So once you find that tubing, you use the L-hook cautery all the way up into where it kind of gives you a clue where it's diving underneath the liver and into around the cardia of the stomach. And then from there, you just chisel through scar on the tubing until you find the buccal. The key with removing these is finding the buccal. Now, whether you're doing it laparoscopically or endoscopically, I mean, I think doing an exploratory laparotomy for this is not any easier, in fact, probably harder. But you know, people do remove these endoscopically as well. So, patient has a scope and the buccal is hanging inside the stomach. That's the main area that is hardest to get the scar off of when you're operating on them laparoscopically. But once you mobilize the buccal, you can cut the band and remove it smoothly from around the stomach. And where you want to cut it is the main body of the band here, not necessarily just the buccal and try to pull it through, because it will not pass through that posterior tunnel that it has created. So to be able to remove it endoscopically, you want the buccal hanging inside the lumen of the stomach. What we do is pass a JAG wire, which is an ERCP wire, get it between the band and the stomach. You snare it, pull it back up, and then you use a Shohendra lithotripter, which is used by the GI guys to break up biliary stones. And this part, if I can get the mouse to work, this part goes down with essentially and scissors the JAG wire through the band. So once you cut it, then you can go in with a grasper or a snare typically, grab the buccal, and then it comes out slowly, or pretty smoothly actually. Then once you have the tubing, you can cut the tubing with endoscopic scissors and then pull it out. So that's pretty impressive. If you're going to remove it laparoscopically, again, just find the tubing, use a cautery to get all the way down to the buccal, lift up the liver with a Nathanson retractor or an assistant. I like to approach it from laterally to medially, because medially, as you get on the lesser curve side, is where you're going to get into a lot of thick, lesser curve gastric mesentery and arterial bleeding. If you can find it laterally, then you can start to wiggle it and move it around until you get that buccal free, and then you're home free after that. If you're left with a hole, typically when I book one of these, I'll ask for an endoscope as well, just so I can kind of guide, with the light from the endoscope to see where I am in the stomach, and then eventually find the eroded area. You're going to need to whip stitch that closed. You don't need to resect it. You really can't. It's not going to hold staple lines very well, and it's too thick. But if you whip stitch it, put Omento patches, and then put drains everywhere, typically they'll heal up, because the distal stomach is not going to act as a stenosis and cause this fistula to remain open. They actually heal up pretty well and resist the urge to get any upper GIs, because they will not look normal. The contrast will fill that old tunnel. It just won't look right. And then you'll be wringing your hands on what to do next. Personal experience. They do tend to form collections and abscesses if you don't drain them. So put the drains into the tunnel as much as you can, and also treat them with antifungals as well. So what do you do if you have a patient that's, need their band unfilled, and, true results is closed shop and left, and there's no bariatric guy around? You need a Huber needle. You need a long Huber needle. Most ORs that will have these, or you'll be able to find them. And you take a 10 cc syringe. You feel for the port between your fingers. Just try to feel around where the tubing is until you get a good idea. You can ask the patient to flex their abdominal muscles, or just lift their head off the bed, lift their head and their legs, and that kind of gives you a background to be able to pin it between your two fingers. Alcohol swab, and poke at it until you hit the diaphragm, which you'll feel is pretty soft, and then the posteriorly is metal, so you'll feel that clink, and just suck all the fluid out. Most of the patients will immediately do well from that and feel relief. You can give them a PO trial, and if they're tolerating that, they can usually go home. The ones I would observe, if they're coming in and they have epigastric pain, they have a white count, you need to immediately empty this band. I would resist putting in any NG tubes. You're not going to drain anything. You could perforate something if they have a slip and they have thinned out stomach or esophagus above that. Just put their head elevated, make them NPO. I like to get a gastrograph and CT. It's water-soluble contrast. It gives me a shape of the stomach, gives me a shape of the esophagus, where the band is, what's going on with it. Upper GIs, typically are hard to get in the ED anyways, so they're not very helpful. If you empty the band, a patient came in, has epigastric pain, has a white count, you emptied the band, I would observe that patient overnight. If they still have epigastric pain in the morning, or they're not looking right, you need to be pretty expeditious in getting in there and getting a look at the stomach and getting the band out. You can get gastric necrosis with this and gastric ischemia, and once you have that, it's very hard to be able to resect fundus close to the cardia and close to the EG junction safely and without issues. So I'd have a very low threshold to take these patients to the OR and remove the band. Lap bands, I hate them, you hate them. We don't know why we hate them. They helped a lot of people, but the ones we're seeing are the ones that have issues. I think of them as opportunities, to treat weight loss failure or complications with bariatric operations. So we need to find these patients and get them in and get the bands out and get them operations that work. Sleeve gastrectomy is the most common operation now. Essentially, we staple and cut and remove the lateral portion of the stomach. Making a tube out of a bag is how I describe it to the patients. So inherent to that, it has some technical issues that can develop. The benefits are there's no intestinal bypass, it's stomach volume reduction, and so thus it's considered restrictive, but it also has a hormonal component as well. When we remove the fundus in the body, where the main cells that produce ghrelin, which drives the sensation of hunger is severely blunted. So they get the benefit of less food makes them feel full, and they're not hungry all the time. So with that feeling of satiety and hunger drive that's minimized, they're able to lose weight. And so the stomach doesn't act as this big reservoir that's trickling food into the small bowel over an hour or 2 hours. And food gets into the small bowel a lot earlier, so it's setting off a lot of satiety mechanisms as well. It accounts for greater than 50% of the bariatric cases. Excess weight loss with it is about 60 to 65%. It has the lowest short-term and mid-term procedure-related morbidity compared to Roux-en-Y and BAN, so that's why it's very popular. And weight loss with it is pretty good, and comorbidity resolution is comparable to a Roux-en-Y. So I have a hard time offering Roux-en-Ys now in a patient that just has weight-related issues and a handful of comorbidities. There's no surgery on the small bowel, less risk of nutritional deficiencies compared to a bypass or a duodenal switch, and it's less demanding follow-up. I'm worried about a sleeve patient a lot less than I am a bypass patient if they get lost to long-term follow-up, given that. Disadvantages: very long staple line, probably the longest staple line we use in all of GI surgery. Takes about anywhere from 4 to 6 loads of a 60 millimeter endoscopic stapler to get across that and create that sleeve gastrectomy. So main issues that we have is it's not reversible. We're removing about 80% of the stomach here. When they go well, but it's very difficult to manage leaks when they develop, and you can get de novo GERD in patients that have never reported it before. Leak rates, we're in the 0.3. We're closer to 0.3% leak rate these days than we are to the 7.8 in the early days, but on average, a lot of reports are around 2%. Stenosis and stricture rates are about 2%. I include kink in that because each stomach has a different shape, and I don't think you can tailor the same tube out of different shaped stomachs, and that's why the incisura is really important to me when I'm doing one of these operations. 30-day major complication rate is about 0.96%. 30-day mortality is about 0.08. So one of the safest major operations done, lower mortality rate than gallbladder surgery, hip surgery, hysterectomies, and so on. Conversion rate for weight loss failure is around 4.7%. For reflux, which is kind of an issue that we're debating in bariatric surgery as to is it treating it, is it causing it, is about 2.9%. So typically the way I perform my sleeve gastrectomy is, first thing I do is I map out where the pylorus is, and I count back about 5 centimeters, and then I look at where the incisura is. If the patient has a really J-shaped stomach or kind of angulated and coming out, I'll come more lateral to that just to keep the tube straight. And then I use a 40 French gastric calibration tube. I don't use a solid or blunt tip bougie. I use what's called a VisiG tube. It has basically small suction holes along the distal 10 centimeters of it. It's very soft, very pliable, very easy for the anesthesiologist to pass it. Before we start the operation, they can decompress the stomach. I do the dissection, and then they can pass it into the antrum, place it on suction, and it stays in place. And then I kind of staple the sleeve gastrectomy around the tube. So typically I'll come back 5 centimeters from the pylorus, paying particular attention to the incisura, and then aim for the angle of His. And then once I get to the angle of His, and I look for that by taking the epigastric fat pad off. Take it off the diaphragm and lift it up enough. I don't try to resect it completely. I just kind of start laterally and lift it up, and then aim for about a centimeter from the angle of His, and then I let that fat pad kind of flop over it. Then we leak test it. Complications of sleeve. Again, nausea, vomiting. EMEND has really changed this operation to a 2-day stay to an outpatient procedure, because once you manage their nausea and they're stable and sipping liquids and taking liquid pain medicine, Lortab elixir, we can typically get them home in 4 to 6 hours after the operation. Reflux is an issue. Kinks, if there's an angulation at the incisura, when that sleeve fills with food, it'll kink more, and they end up with reflux and vomiting issues. Post-op bleed is an issue. Leaks. Everyone hates, anyone who does GI surgery hates to see a JP fill up with one of these. DVTs are a particular risk. In sleeve gastrectomies, we see a higher proportion of portal vein and splenic vein thromboses. We're not sure exactly why. So that's a little bit unusual. Sleeve bleeds are less than 2%. Typically, they'll happen from these short little branches off the epiploic near the antrum because it gets really close here, and when you're taking it off with a ligature or a harmonic, they really don't, they're kind of ending right on the epiploic, so they can blow out kind of easily, or the short gastrics when you take down the fundus. Sleeve leaks are again in the 0.3 to 2% range, drop from earlier rates of 6 to 7%. Contributing factors are ischemia, distal kink, and stenosis. This is kind of a bad picture of a sleeve. This should kind of end probably over here. But leaks happen at the proximal staple line. If you have a kink here, this progressively kind of dilates up and kind of blows out this corner, or you get ischemic segments here. We classify them as acute, early, late, and chronic based on time course. Within 7 days is acute, 1 to 6 weeks out is early, and then 6 to 12 weeks out is late, and beyond 12 weeks is chronic. And this mainly has to do with how we manage it. If I have a leak within day 1 or 2, I take them back to the OR, wash it out, put some drains, overstitch it, and put an omental patch. But beyond 3 or 4 days and into the first couple of weeks, there's nothing up there that's going to hold a stitch very well, so we stent them, and I'll show you that. Beyond 12 weeks is when you got to start thinking about a secondary operation to manage that leak beyond stenting and simple measures. Patient comes in with signs and symptoms of a leak, which are typically unexplained tachycardia, fevers. They may or may not have fevers. They may or may not have abdominal pain. Again, these are morbidly obese patients that can hide a lot of pathology in their belly. The principles are drainage, antibiotics, nutritional support. Stenting is becoming a more and more common modality. I know how to manage these. There's over-the-stent clips that basically kind of looks like a bear trap that sits over the stent. Once you find the fistula, you can pull it in with a grasper and put a clip over it. We don't have those at Harris, so I haven't started using those yet. I'm asking them to order it. But endoluminal stenting is becoming really important in the management. And then percutaneous drainage. There's a colleague of ours in Dallas, Steve Leeds, who has kind of popularized the NG tube sponge. So he takes what you're familiar with, which is an NG tube and a sponge from the KCI VAC device. He attaches that, takes it down endoscopically, passes it through the fistula, and places it to suction to essentially empty out that cavity. And then if beyond 12 weeks these are not healing, we need to start thinking about gastrectomy and esophagojejunostomy, or even bringing up a roux of small bowel and sewing it to the fistula itself. Principles are: you got to drain the swamp, you got to get the saliva and gastric juices and things to go past the fistula. You got to drain the abscess itself. Most of these will heal up around by 9 to 10 weeks. In a study looking at sleeve leaks in their patient population, this was from, I think they looked at 800 patients. They had 10 leaks. Most of theirs healed by 9 to 10 weeks. They had 2 interventions, which was basically stent removal and replacement. Boston Scientific makes these stents. They have partially covered or fully covered stents. And the principle is just basically put the body of the stent in the sleeve and against the fistula to prevent anything from constantly and preferentially going through the fistula into the drain, and have it go distally into the GI tract, and they heal up. We bring them in, we remove them every 2 to 3 weeks, and then replace it. Look at the fistula. Is it smaller? Is it there? Is it gone? This was actually one of my patients. She had a series of issues and then developed a leak. This is about 15 millimeters here on this upper GI, and this is immediately after stenting. Get an upper GI, you see that the contrast is preferentially going into the duodenum. So management is conservative. Suture repair with an omental patch. Some people put T-tubes into these to control the fistula. Beyond 12 weeks, you can start thinking about a fistula jejunostomy, where you're bringing up that roux limb. Stenting is the preferred modality, and the majority of them will heal with stenting. And then you can start thinking about what part of the sleeve you have to cut out and perform esophagojejunostomy. Bypass, tried and true operation, a very good and elegant operation. Volume of these cases have gone down dramatically with sleeve gastrectomy being so popular. Excess weight loss with it is about 60 to 80%. You have a restrictive component of the small pouch and a very big metabolic component with a reduction of ghrelin, increase of GLP-1, and early stimulation of peptide YY from the right colon as food is diverted to the small bowel. And then, so the terminology here is, we call this the gastric pouch. This is the gastrojejunostomy. This is the roux limb. Call it the remnant stomach, and then the biliopancreatic limb, and then the common channel. And this is kind of the language we use when we're looking at CT scans and talking to the radiologists and trying to figure out something on CT scan. This is both a restrictive and metabolic operation. The restrictive component is a small pouch, and the metabolic component we talked about. Weight loss with it occurs out to 18 to 24 months, and their weight stabilizes and their lifestyle changes or what's going to keep them there. We do have level 1 evidence through the STAMPEDE trial that shows that this is more effective for management and treatment of diabetes and long-term remission compared to sleeve gastrectomy, but at the cost of a much bigger operation. Disadvantages are dumping syndrome, nutritional deficiencies that can develop if the patient's non-compliant. Leak rates are still pretty low at 0.4%. Stenoses and ulcers, I'll show you a patient with a stenosis that we managed again with newer techniques of stenting. DVTs are still an issue. Bowel obstruction is the most common complication. 30-day major complication rates are still pretty low at 1.2%, and mortality rates are 0.14%. Bypass complications, the most deadly is DVT-PE. Stenosis are an issue and a nuisance, early or late leak. I'll take a bypass leak over a sleeve leak any day, just because you have that roux limb that's constantly peristalsing away from your fistula, so your likelihood of healing that is much better. Marginal ulcers, which it can account for 2 to 5% of the complications. Now, if a patient comes in, epigastric pain, they have an ulcer, you got to solicit the history of NSAID use, smoking, or oral steroids. Bowel obstruction is the most common complication, with internal hernias being a big component of that. That can happen in 2 to 5% of the population with bypass patients, either early or late, and then nutritional deficiencies. I guess the most important thing is to pick up an anastomotic leak and a lot of their complications early. Do not ignore a bypass for a sleeve patient who's tachycardic for no explained reason. When they come in, they need full workups, even if they have just the most simple abdominal pain. If they're calling and coming in for it, it warrants a workup, including a full panel of labs, CBC, CMP, and I always like to get a CT scan just to see what's going on. You'll be surprised on what you find a lot of times where their exam and just their general appearance will hide until it's too late, and then they tank quick. These patients have a bad reputation for, they're really, they have a complication, they tank really quick. I think a lot of times there's, what they're calling about or what they're trying to tell you is ignored or downplayed. Because their abdomens are so big and there's so many peritoneal surfaces, they can hide a lot of issues. They can hide an abscess and give you no peritoneal signs or focal peritoneal signs at all until it's too late and they're systemically sick. If a patient comes in with a left pleural effusion a week or two after surgery, even otherwise looks well, I'd be looking for a leak. They may or may not have fevers. They may or may not exhibit peritonitis. The key is to fluid resuscitate them, give them a couple of liters of fluid, start some antibiotics. I always add antifungals because these are proximal issues if they are leaking from the sleeve or the gastrojejunal anastomosis of a bypass. And then bariatric protocol CT, like what is that exactly? Well, it's a short oral prep because you're interested in the foregut. It's a short oral prep, water-soluble contrast, and I always either talk to the patient, the nurse, and the ER physician and tell them to send them over to CT with a cup of contrast, and right when they get on the gurney, right before they lay down, to drink a little bit so you can see what's in the esophagus and the proximal stomach. And early intervention is the key with these. So perforated ulcers, they show up in ERs, years after a gastric bypass that has been successful. The point I want to kind of drive home here is these patients don't always need an exploratory laparotomy. Often they can be managed with laparoscopic approach, and in some instances you could, potentially, depending on how they're doing, how they look hemodynamically, just manage them with NPO, IV fluid, and antibiotics. Because, you have the esophagus, a small pouch, and a roux limb that's emptying it. Unless you have a lot of fluid in the left upper quadrant that you're trying to drain or wash out, you're not going to do anything. You're not going to see much. There's a big inflammatory process up there. You might find a little pinhole if you're lucky. All the best you can do is put an omental patch on that and then drain it. If you have a bigger ulcer than that has perforated, if it's a centimeter or so, I will put a figure of 8 Vicryl tie in that, or a suture in that, and then put an omental patch, widely drain it, plus minus a feeding tube, and then keep them NPO for 3 to 5 days, and then follow it up with an water-soluble upper GI to see if it's draining, if it has been controlled or not. And then I start them up on a liquid diet, protein drinks, and then advance them by 3 or 4 weeks out. So the point is, they don't need an exploratory laparotomy. You don't need to resect the ulcer at that index operation where they're showing up with a perforation. And if there's nothing to drain and the patient's hemodynamically stable, you could potentially just resuscitate them and put them on antibiotics and not have to operate on them. My port placement for all these operations, whether it's putting in a band, taking out a band, sleeve, bypasses, typically looks like this. This is where my camera goes. I use a 12 millimeter port here, sometimes a 5, depending on patient and or what I'm doing. Then this is the mid-clavicular line, mid-abdomen, 12 millimeter port, 12 millimeter port here, and then 2 subcostal 5 millimeter ports, and the assist can help you through these. And then this is for a Nathanson retractor to lift up the liver. My approach for internal hernias is roughly the same, except that these ports might come down a little bit more so I can work on the lower abdomen if I needed to. Internal hernias happen when we do bypasses through a couple of different windows. So again, the terminology, this is the common channel, the jejunostomy. You'll get 2 leaflets of small bowel here. There's a window that we typically will suture close here, either with a purse stringing or a running suture. And then this is where the pseudo-Peterson's defect is. Peterson's defect was described with a retrocolic roux limb. This is most of the procedures or gastric bypasses that have been done in the last 10 years or so. The majority of them are anti-colic, anti-gastric, and the small bowel configuration is this way. So you can get the biliopancreatic limb to slide up underneath here. You can get the roux limb to get in behind itself. I have seen the entire common channel, roux limb, and the anastomosis up in the left upper quadrant that the patient had been living with for a while until she couldn't tolerate it anymore and she came in. Typically I'll start, so these occur at the rate of 2 to 5%. The patients typically present with a history of periumbilical pain, very intense. They may have listed a history of this over the last year or two that's been progressively getting worse, and it comes and goes. They curl up on all fours, lay on their side, and then eventually it goes away until this time where they landed in the ER. The key is to pay attention to these patients. If you have a bypass patient that comes in with abdominal pain, question of small bowel, or partial small bowel obstruction or something of the sort, is to not ignore them and get a CT scan. If a CT scan is, it has pretty low sensitivity for picking up an internal hernia, but a pretty high specificity. So if the CT is showing you that, they need an exploratory, a diagnostic laparoscopy, and basically looking for these windows and to reduce any hernia or small bowel that has herniated through a window, and then closing that defect. If a CT is negative, the abdominal exam may be equivocal. If the story is good, a diagnostic laparoscopy is warranted. Do not ignore these patients. They can go home and show up 3 days later with their entire small bowel incarcerated and infarcted by that time. It's too late. Part of the problem here is there's no consensus on who closes what. The bariatric surgeons, about 94% of them close at least one window. That's typically the jejunostomy window. Here, you know, the retro roux window, most people do not close, but if you do, you have to make sure you're doing it correctly, which is you have to flip up the transverse colon and make sure you sew it all the way to the base of that, because you don't want to take a big hole and then sew up most of it and make it a small hole, and then that's where you set up the patient to develop a hernia there. Again, low threshold for diagnostic laparoscopy. I put the ports again at the umbilicus and across the belly. I start at the ileocecal valve, follow the common channel, identify the jejunostomy, look at the window between these. If it's got herniated bowel in it, then it will be very confusing to look at. You can't tell what is what. So the next step is I follow the BP limb all the way back, and then back to the jejunostomy, try to get that oriented. And by doing those two steps, a lot of times you kind of have reduced it and not realize it, and then I look for the window, and then from there I look at the roux limb going up. If it's entrapped, you can't pull on it, it's already dusky, you have to open, resect it, come back for a second look, and then put the patient back together. At that point you can do what you need to do. And closing the Peterson's defect, again, if you are going to close this, make sure you're closing it all the way and not making a big hole, a small hole. You know, gastric bypass obstructions, you have to figure out where the obstruction is. If it's at the gastrojejunostomy and you have a stenosis, that's one issue. If it's at the jejunostomy, you know, you're going to have a dilated roux limb and the patient vomiting foamy stuff or food they ate a couple days ago. Or if it's bilious, you know, you've got an obstruction somewhere in the common channel and it's coming back up the roux limb and out the mouth. When you look at these CT scans, that's where the terminology becomes important, and kind of understanding the anatomy and what's the setup is to trying to figure out where the obstruction is. You look to see if there's dilation of the gastric remnant, dilation of the roux limb, is it anticolic, retrocolic, things of that sort. You can also get intussusceptions. This is actually a swirl from an internal hernia. If you see anything like this, that's pretty suspicious for an internal hernia, despite the fact that there's no dilated small bowel. So a lot of times they act like they are closed loop obstructions. Stenoses at the GE junction have become a little bit more fun to treat these days than before. This is actually a patient that's about 12 years out from a revision of a vertical banded gastroplasty and another abandoned procedure, who had a Roux-en-Y. About 12 years ago in San Antonio, he started to develop stenoses. This was serially dilated. At some point that he had a perforation. It was managed operatively. And then he did well and disappeared. He showed up in Fort Worth with complaints that he can't swallow anymore. So when I scoped him, he has this pinhole little defect, and this is about 3 weeks after a gastroenterologist had dilated him. So no malignancy at this. This was biopsied multiple times. So I learned about this stent. It's called Axios. Boston Scientific makes it. Kind of like a barbell shape. The issue we have with stenting a gastrojejunal anastomosis is because it's long and soft and the small bowel is always peristalsing, it never stays put, so it immediately migrates into the distal small bowel, and then you're having to fish it out of the ileocecal valve because they typically can't pass it through that. With these stents, it's barbell shaped, so it sits across that narrowing really, really nicely. I can tell you these pinholes are the toughest ones to dilate because you don't know where your guide wire is going. You can do it under fluoro, which gives you some idea, but these are the ones you perforate and you come out and you're looking at liver and the rest of the small bowel, so immediately you go to the OR for that. But with this, if you can put it in place, it's really actually nice. So up here is with the stent deployed, so you can tell it has a big waist that is trying to push out against this this stenosis here. I brought him back about 3 weeks later. It's fully opened up, not a whole lot of erosion or trauma at the anastomosis, and it's widely patent. He did have, I left him alone here and brought him back 2 weeks later, scoped him, and he had started to narrow again, so I put another one in for another 3 weeks, and I haven't heard from him in about 2 months now. So it was either this or after 12 years of dealing with serial dilations, an esophagojejunostomy, which is inherently at risk of doing the same thing. So I'm happy if he gets this. He's happy if he gets this 2 or 3 times a year and goes about his way. Intussusceptions are extremely rare, but they typically happen at the jejunal anastomosis. You get this target sign pattern on CT scan, and you can try to reduce it laparoscopically, but it's really hard when you have that much bowel to pull out. So it gets really difficult. The other thing to do, after this case, I thought to myself, well, we knew we were going to resect it. Why did we open it? We should have, resect the jejunostomy completely and put it back together. Because reduction alone without embrocation leads to pretty high recurrence rates. So weight loss comparisons, small, medium, large. Actually large, medium, small. So Roux-en-Y, sleeve, and bypass. Weight loss is most significant with the Roux-en-Y. Next, the sleeve. Lap band is thereafter. Average weight loss maintained is about the same for sleeve and bypass, a little bit less with Roux-en-Y. In summary, 30-day mortality rates between sleeve, Roux-en-Y, band is pretty low when you compare it to other surgeries that we do every day. And the point of that is not to say that it's any better or worse. It's just that, I think bariatric surgery gets a bad rap for being a complicated operation in patients with issues, and it really isn't. Leak rates are pretty low. Reoperation rates, I think, are probably underestimated. Again, we're dealing with a chronic disease. So with that, I just put in a handful of questions that might help our CME talk. What's the most common cause of death after gastric bypass? Perfect. Patient presents to the ER years after a lap band placement with persistent vomiting and PO intolerance. What's the move? NG tube, IV fluid, antibiotics. See them in the morning, or or NPO. Avoid NG. Head of bed elevation. Huber needle and empty the band and get a CT scan. You removed about 7 cc's. Patient had an elevated white blood cell count and persistent epigastric pain. What's the next move? Go to the OR, take it out. 10 years after Roux-en-Y, patient with significant weight loss. 75, 80, or 100% or 100-pound weight loss, presents with intense abdominal pain. They moved here from New York City where they had their operation. They have normal white count, belly soft, nothing much on CT scan. What are you concerned about in this patient, and what would you do next? I'd try to talk to them some more and figure out how often they're having this, what their symptoms are. I'd keep them in-house, and if I had any suspicion, I'd stick a scope in, make sure they don't have an internal hernia or window that's open that's having intermittent volvulus or internal hernia. All Roux-en-Y gastric bypass patients presenting with perforated marginal ulcer must undergo exploratory laparotomy and ulcer repair and possible resection. True or false? False. And it also depends. I mean, if you have a bleeding ulcer and you can't manage any other way, then you're the surgeon at that hour managing that. But most of these you can manage laparoscopically, and in very rare instances, if it's just a few blips of air and no fluid to drain and the patient's doing well, maybe non-operatively. Thank you very much. Sorry, I know that was a lot of different things, kind of globally going over some of the procedures and some of the bypasses.
Bob, you have a question?
Yes, sir.
Congratulations, very comprehensive discussion of the bariatric surgery. I did QA for Texas Medical Liability Trust for more than 20 years. The most common cause that I saw with these was a malpractice case with failure of the surgeon to respond to very subtle signs of complications, which, like you say, are not typical in an obese patient.
Absolutely.
And then they're all going home, and then gets away from them, and it progresses.
Absolutely. And that's what I try to tell the staff in clinic when the patients are calling post-operatively. I said, do not ignore a single thing that they're saying. If they're talking to you about nausea, vomiting, go through what they're eating. If things don't sound right, they need to be evaluated. And even when they show up in the ER, a lot of times the ER attendings for a while were hesitant to call, saying, something trivial like nausea, vomiting, as you would expect. I work them up. I get their labs. I get a CT scan. They harbor a lot of different post-op pathology that are very subtle, and if you ignore it. I had a guy, Forward City employee, great, gentleman who he just for 2 weeks just had this persistent nausea that just wouldn't go away, and ended up. Otherwise, he looked fine. no white count, belly's soft. I ended up getting a CT scan on him when he called back at week 2, and he had a great big portal vein thrombosis. You know, I would have never picked it up any other way unless we had a good contrast study on him. We treated him with Lovenox and Eliquis, and after 6 months when he came off, we got him worked up. He actually had a protein C deficiency. So you can't ignore their issues when they come, how trivial it is.
Since I'm the internist here, it's often when I go to meetings, I go to a lot of lipid meetings, cardiometabolic meetings, and it's not uncommon for us to have presentations about weight loss surgery. But the phrase I hear talked about more and more is metabolic surgery.
Mm-hmm.
Because as you pointed out, all the things that we deal with in internal medicines that are aggravated by obesity are dramatically improved by whatever weight loss people can achieve. I'm curious about whether within the surgical community that term metabolic surgery is starting to be used more commonly, and if maybe that would be a way to help stimulate insurance companies to start looking at this with a more friendly eye.
Absolutely. You know, we realized that something, and that's one of the things that attracted me to bariatric surgery is, you know, immediately post-op you see, you know, blood pressure correct ahead of the weight loss. You see insulin resistance go down ahead of the weight loss. So there's some gut physiology that's changing immediately. There is that, and I also think that part of it has to do with how restrictive these diets are going into the operation and then coming out of the operation. I have them on a liquid diet for about 7 to 10 days to help shrink some intra-abdominal fat, shrink the liver, you know, take out a lot of the thickness and the bowel and the stomach. And so they're not exactly starved, but they're not eating the things that they were that are pro-inflammatory. You know, a lot of the processed foods and the high sugar foods that they're eating are kind of washed out in that. So I think that's where, you know, I really think that the food that we're exposed to is pretty toxic. So yes, metabolic surgery is the way that we're talking about it these days, because that's really what's going on. There's gut physiology that's changing here that's pushing all this.
Steve?
Yeah, legislation's in session right now in Austin. In fact, the next first Tuesday is March the 2nd. I recommend that to anybody. What is your support from the legislature on this? Is your insurance coverage improving? Does this need to be a topic that we discuss as we're making our round with our legislators for advocacy for our patients, that they need to support this more? Are we doing okay?
Yeah, so the question was, what do we need to do in terms of advocacy at the state legislature level? So just to give you some background, about 50% of the commercial policies out there have excluded bariatric surgery as a benefit. So they've excluded morbid obesity as a diagnosis code that they'll cover, and the CPT codes of these operations completely. TABS, which is the Texas Association of Bariatric Surgery, has recently submitted some legislation for universal coverage for weight loss operations. Now the details of that bill I don't know exactly, as they did it just a couple of days ago, but yes, this is something we need to support. And I think Texas actually is one of the states that requires and mandates you know, that morbid obesity is not excluded from policies. However, self-employed plans are the ones that we're seeing that are excluding it from for coverage.
Yeah, the strategy on the first Tuesday and going to legislature works much better when you cross-pollinate. So I'm an orthopedic surgeon. You get better results if I'm down there lobbying on that. So I'll talk to you more after the hour. And then if there's a chiropractor bill I need to get you to help me with, I'll be
Yeah, my pleasure.
Dan?
Yeah, where do you see bariatric surgery 5-10 years from now?
You know, with the rate that new devices are coming, so the question was, where do we see bariatric surgery 5 to 10 years from now? Well, you know, I showed you that statistic that about 42% of the population is estimated to be obese by 2030. So, you know, it's just going to become a bigger problem because we have our head in the sand about what we're going to do about it, number one. Number two, there is a huge push from industry, device makers, more so than the medical community, into how do we stem this tide? How do we start approaching it? And I don't think the answer is just surgery. I think we know maybe the tip of the iceberg about obesity. I think we have a dearth of knowledge about, there's different types of obesity. We need to categorize it. I mean, there's obviously volume eaters, there's genetics, there's behavioral, and then, we have patients that have a high BMI with no inflammatory component, and then we have patients that are just, the majority of them being metabolic syndrome type patients. So I think that research will continue to expand. I think that we need to push legislature, and eventually we'll get, some incremental change and coverage for it. And then what operations we'll be doing 5 to 10 years from now, I couldn't tell you, because at the rate that, people are innovating and thinking about different operations, it's hard to keep up, just as a bariatric surgeon.
Do we have any questions from Decatur? Okay, yeah, I think we had one in the back. Did you have your hand up back there?
Yeah, the question I have is, I know you made fun of the, spray in or whatever and get rid of 30%.
Oh, Aspire, yeah,
Right,
surgically
Aspire.
induced bulimia.
But with that how are they taking care of the acid coming up and everything else and the esophageal problems that can create? Is there something in the fluid that's supposedly helps to coat?
No, so this is, and I don't know a whole lot about it because I don't use it, I haven't studied it, we haven't seen it hit prime time so much, but essentially it's same as a G-tube, and what they connect it to is a pump that irrigates out the stomach. So if they have reflux issues before they even had this, yes, it'll probably make that worse, but I don't see how, if they don't have reflux issues or a bad valve, it's not like they're putting excess fluid in there. What they're doing is they're using fluid to wash out the food particles. So essentially it would probably make reflux better, because to have reflux you have to have a bad valve and a refluxate. So if you're washing that out, it should be improved. Yeah, it is. But that device speaks to the need. Well, how we got to manage this.
I know people that do. I mean, there are people that do it, right? They
Mhm.
eat and everything else. All they want, and they just go to the restroom and then
Purge. Is there someone here in Fort Worth putting those in? I mean, not that I would condemn their practice or anything like that. It's distasteful, but obviously it's treating a problem and a disease.
Well, Sam, thank you very much. I learned a lot.
Thank you very much. Appreciate that.
I can't tell you how glad I am I'm not taking general surgery emergency call these days. Thank you very much.